IMG 340, thoracic and cardiac CT imaging. Mediastinal clinical indications. Almost all mediastinal abnormalities detected on chest radiographs, typically suspected masses, or suspected from clinical evidence, can be confirmed with CT imaging. CT is the most commonly used modality to detect lymphadenopathy in patients suspected of having bronchogenic carcinoma, lymphoma, or other malignancies. In these cases, CT is used to determine the extent of the invasion of the chest wall, mediastinum, and diaphragm, and to detect extrathoracic metastasis in the liver and also as well as the adrenal glands. CT as well as MRI does have some limitations. One of them is that they are less efficient at detecting tumors within normal size nodes or from differentiating between enlarged hyperplastic nodules without a tumor and tumor-containing nodes. With the use of IV contrast on vascular structures in the mediastinum, aneurysms can be differentiated from other mediastinal masses. CT is highly accurate and comparable to MRI in detecting and defining the extent of traumatic aortic ruptures and aortic dissections. Regular angiography is now rarely used to confirm these diagnoses because CT imaging is so prevalent with this type of diagnosis. One of the most common exams to image the mediastinum that uses contrast is CT angiography or a CTA. You'll often will see a CTA of the aorta ordered. It could be of the chest aorta or of the abdominal aorta, but the reason that the doctor orders this is to rule out a dissection of the ascending or descending aorta. So with this slide, I just wanted to show a few pictures of what are some examples of mediastinal imaging in CT. So this picture here on the left shows a with contrast exam, and you can see that the white area here is the descending aorta, and it is bright white, which means it is being imaged using contrast. It is normal. You do not see any dissection. And then this picture right here is just a normal 3D reformation of the abdominal aorta. And then the picture here on the right, this is basically a CTA of the chest. So what you're seeing here is the ascending aorta right here, the descending aorta right here. This is not a normal study, as it does show a dissection actually in both the ascending and in the descending aorta. This is a very critical patient. Once you see a dissection, time is of the essence, and you need to alert the doctor immediately. CT is the most sensitive technique for detecting pulmonary masses. However, increased sensitivity is achieved at the price of decreased specificity. It's very important not to get these two mixed up. Sensitivity is the likelihood that a test will be positive in an individual who has the disease. Specificity is defined as the likelihood that a test will be negative in an individual who has no disease. Benign lesions like subpleural lymph nodes and granulomas and a greater number of metastatic lesions can be detected on CT imaging. Helical CT is more sensitive than ventilation or perfusion scans. These are a type of nuclear medicine exams, and they're of equal specificity in detecting pulmonary embolisms. Pulmonary emboli are seen in a CTA chest exam, and they are seen as filling defects in an enhanced pulmonary artery. So they are seen when the pulmonary arteries are imaged using contrast. CT will miss clots, however, in the smaller sub-segmental branches. One thing I want to point out in this picture is that this line right here is the pulmonary embolism, and there's also one right here as well. So essentially what you'll see if there is a pulmonary embolism, or also known as a PE, you'll see the contrast in the pulmonary trunk right here and through the right and left pulmonary branches be white, but if there's a pulmonary emboli, it will show up as dark contrast where the, as a darker density where the contrast is not filling that part of the anatomy. High resolution CT, also known as HRCT, uses thin sections to evaluate lung diseases. HRCT can show diagnosis for asbestosis, silicosis, and idiopathic pulmonary fibrosis, as well as emphysema and bronchiectasis. HRCT is more sensitive than chest x-rays for detecting emphysema, and here is a picture of an image showing pulmonary fibrosis in a high-resolution CT image. Multi-slice CT imaging is the best way to view patients with blunt chest trauma. Common injuries from blunt chest trauma could be a pulmonary contusion, which is basically a lung bruise, a pneumothorax. And I do want to point out with a pneumothorax, this is when there basically is the presence of air or gas in the cavity between the lungs and the chest wall. And this actually causes the collapse of the lung. So a pneumo shows up as black. So there's no lung markings whatsoever, as in this picture. And here are your regular lung markings, and this is where the pneumothorax is. Other common injuries are a tracheobronchial laceration, diaphragm injury, and a chest wall or spinal injury. The technology of the very latest generations of CT scanning are combining very rapid scanning with thin collimation, extended range, and electrocardiographic gating. And this now provides us with the ability to help accurately study the coronary arteries in a non-invasive manner. This is known as a coronary artery calcium scoring exam. It can assess the degree of coronary artery bifurcation, obtain angiograms of coronary arteries, and display these images in 3D reformations. And it can also even eliminate the need for an invasive and risky catheter angiography, which is done in the cath lab. So with the coronary artery calcium scoring exam, they are now widely performed to detect the extent of calcification in the coronary arteries and also to help the clinicians manage patients at risk for myocardial infarctions. An exam like this typically has 45 to 65 images taken for it, and areas of calcification in the 5 major coronary branches are marked. And each plaque that is found in the arteries are assigned a score on the basis of its area as well as its density. All scores are then added and adjusted for age and sex on the basis of existing data files. Coronary arteries are very challenging to image due to their small size, their tortuous course, and pronounced rapid motion from the beating heart. Cath lab angiography used to be the gold standard for imaging the coronary arteries, but now CT is actually a close second due to the non-invasive manner that it uses. So the patient preparation is just about the same for any other anatomy. This is the slide that we first saw in the CT head and cerebral vessels lecture. So you need to remove any metallic objects. Fasting isn't usually necessary, although don't have them come on an empty stomach if they will be receiving contrast, as it might make them nauseous. Have the patient empty their bladder. Ease the patient's anxiety by explaining the exam thoroughly. Review the known allergies and renal function before injecting contrast. Note cardiac medications, which is especially important in cardiac imaging and CTA imaging because it can it usually shows signs of any abnormal cardiac output. Get the patient in a comfortable position and have the patient close their eyes if using the laser to position, and use restraints or body fluid protection with combative patients. Scanning usually begins and ends superiorly from the levels of the clavicles and extends to posteriorly to the costophrenic angles. Typically, imaging of the mediastinum is in full inspiration during a single breath hold. So you have the patient take a breath in and hold it for the exam. Misregistration of artifacts is not a problem. if there's a single breath hold, and the prone position may be helpful when posterior lung base is of concern because it increases the aeration to this area. The mediastinum images should be viewed with at least 2 different window width settings, one that is optimized for the mediastinum and the chest wall, and the other that is optimized for lungs. The patient is generally supine, and the arms are elevated, but the arms need to be not too high that the obstruction of the contrast occurs. So just basically make sure that the arm positioning does not kink off the IV line to the contrast. Contrast usually only is used to see better definition of the mediastinum, and most thorax CTs are without contrast to view the mediastinum. Usually, the scanning of the mediastinum begins with the digitizing radiograph. So, a scout or a topogram, it has various names, and this is done in the AP position. Thicker slices are used 2.5 to 7 millimeters, usually at 1.25 to 5 millimeter slice intervals are routinely used. Thinner slices, like 1.2 millimeters, are used to improve the spatial resolution.